Elshad, can we start? You want to start? You'll be waiting for people. We can start. All right. Like, good morning, everyone. Hello, hello, hello. My name is Shahriyar Zehtabchi. I am emergency medicine doctor from Brooklyn, New York. Thank you for having me. I will be talking this week about neurological emergencies, different neurological emergencies with you. And but I usually like to start with evidence-based medicine because uh, it changes the way you think about medicine. It changes the way you learn, and it will get you into a mindset of how uh, what you learn and what you read affects your patient care. So I always start evidence-based medicine, and then the rest of the week we will just talk about reminders. And I think everyone should start with I think EBM should be taught much earlier in during your medical training, but that's a different issue. I am from Brooklyn, New York. I work in two institutions. One is the State University of New York, Downstate. That's the place that gave you MRI, hemodialysis, and Viagra. It's a tertiary medical center. It's one of the largest medical schools in the country. And then Kings County Hospital. Hopefully, one day you'll get to do some rotations there. It's the definition of wild, wild west. We are in the past 20 something years, Kings County has been #1 in the country for penetrating trauma, gunshot wounds and stab wounds. Uh, not it's not something that we are necessarily proud of, but it's a city hospital, and a lot of uninsured people, a lot of really really sick patients come there, and it's a perfect place for training. So hopefully you'll get to rotate to Kings County, and in 1 month you'll be ready to graduate. So as I said, I like to start with evidence-based medicine. We're going to go through the definition and different aspects of evidence-based medicine. And I'm hoping to change the way that you're going to think about medicine and learn about medicine from now on. It's an ambitious plan, but you let me know if the goal is the objective is achieved or not. By definition, evidence-based medicine is conscientious and judicious use of current best evidence from clinical care research in making health care decisions. Why do we need the conscientious and judicious use of best evidence? Unfortunately, right now, um, the way the medical system works is you have a lot of old, outdated treatment diagnostic tests that people are still using. When new evidence comes, it will take a long time for people to change the way they practice. And when new treatments or new diagnostic tests come up, it will take a long time for people to adopt that those new treatments. Unfortunately, uh, people have access to unvetted information online. A lot of people are getting their medical information from TikTok and Instagram and Facebook. There's really no control over what people can post and um, how that affects people's access to information. And at least in the United States, pharmaceutical companies have they can directly advertise to people without anybody controlling what they're advertising. And of course, healthcare is becoming more and more expensive every day. So you have to use evidence-based medicine to decide what's actually useful and what is not useful. Not every back pain needs MRI. Not every shoulder pain needs MRI. Not everybody with mild chest pain needs to have an angiography. We need to have evidence-based practice in order to reduce the resources that we use. And it's still this is the same, but for the time that somebody, a professor in 1960s or 50s wrote something in the textbook, and then we've been doing that over and over again for decades, or this is how we used to practice, this is how things used to be done, that time has passed. Now we are looking at the medical um intervention and medical treatment and medical diagnosis, hopefully with the lens that is what I have been taught in the past. Is this really justified? What it's been written in the textbooks, are these really justified? So we need to change what we have been learning. And unfortunately, a lot of things that you're going to learn, maybe 50, more than 50% of what you learn during your medical school training is something that somebody wrote in some textbooks many years ago, and we've been just following it. The other reason why you need to you learn evidence-based medicine is to protect your patients. The days that your job as a doctor was to diagnose diseases and treat your patients, that time has passed. Now, probably your main uh, job is to protect your patients from pharmaceutical companies, from bad medicine, from social media, and basically the uh, healthcare, at least in the US, has become a business, and all the corporates are trying to profit from patient care. And your job is to protect your patients from um, the people who want to benefit from healthcare. And unfortunately, there's so much conflict of interest that it's mind-blowing. If you follow the most recent guidelines from American College of Cardiology and um, about statins, probably half of you in this room are supposed to be on statins. If you follow their recommendations for blood pressure medication, probably everybody in this room should be on blood pressure medication. And then when you read at the end of the guidelines, the most recent guidelines had 8 pages of conflict of interest. Basically, everybody that was recommending a statin for, they keep bringing the threshold to treat cholesterol lower and lower. And when you read the conflict of interest, most of them are consultants for pharmaceutical companies. Most of them have been given grants from pharmaceutical companies. The amount of conflict of interest that's going on in people who are policymakers, people who are making recommendation and create the guidelines, is just mind blowing. So your job is to protect your patients more than anything else. This is an example of how celebrities affect our policies. Now, that gentleman who doesn't believe in vaccines and believes that chronic diseases are scams created by pharmaceutical companies is in charge of healthcare system in the United States. And again, unvetted information on the on social media, on internet, have affected a lot of our patients. I even have personally patients who come to me and say, I did this because I saw something on TikTok and I followed their recommendation. Let me give you an example of lack of transparency and conflict of interest. And you will see how you will get an idea about how big the magnitude of this issue is. In during COVID, this Pfizer developed this medicine Paxlovid. I don't know if you've heard of Paxlovid. Has anybody taken it? So early during COVID, Pfizer developed um, uh, Paxlovid, and the outcome that they want to measure was whether Paxlovid can prevent hospitalization and death in patients who have COVID. So that's a great idea. They published the results, and the results showed that Paxlovid actually did reduce hospitalization by about 6 or 7%. Even though 6 or 7% might not be a big deal, but if you're thinking about when we are talking about millions of people like, catching COVID, 6 or 7% reduction in hospitalization is a big deal, right? So the drug showed the drug was effective in reducing hospitalization in patients with COVID. However, during that time, the vaccine wasn't available yet. And if anybody had COVID before, they excluded the patient. So the first study that they did not have anybody who had COVID or had received vaccination. Then after vaccination, they realized that after they did a few months after the vaccination had started, that they realized that now the population has changed. A lot of people had COVID. A lot of people were vaccinated. That uh, cohort that they used for the first study probably didn't exist anymore. That people who never had COVID or never vaccinated, right? So they did a second study, and in that second study, this is the registration. Every clinical trial in the U.S. has to be registered on clinicaltrial.gov, and that way we know when they started, when they finished, and what the methodology is. So if you look at the the date that that study was completed, it was finished on July 25, 2022. This is the study that enrolled patients who had COVID or were vaccinated, and they were given Paxlovid versus um, placebo. So the date that this study was completed was July 2022. They did not publish that study until 2 years later, right? They sat that information. I'm sorry, the results of that study was that Paxlovid didn't work. It didn't reduce hospitalization. It didn't reduce death. So if in people who had COVID or had vaccine, Paxlovid had absolutely no impact. It didn't reduce hospitalization, didn't reduce death. They finished the study in July 2022, did not publish it until April 2024, 2 years. This is a drug company that has probably the best statisticians, the best authors, and they can get a paper out in 24 hours. They sat on it for 2 years. Why? Because Paxlovid was making Pfizer about $4 billion profit every quarter, $16 billion a year in 2022 and 2023. So they the 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 cost of one 5-day course of treatment is $1,300. So they were selling Paxlovid $1,300 per treatment course, even though they knew that their own study showed that Paxlovid doesn't work. They continue to sell it for 2 years, and then later at the end of 2023, the number of COVID cases started to go down. People were not testing for COVID anymore. The sales went down, and then that's when they decided, okay, let's release this information. Let's tell people that it doesn't work. You see the magnitude of conflict of interest and lack of transparency from uh, pharmaceutical companies is just mind blowing. So let's come back to, I don't know why this changed, but let's come back to evidence-based medicine. Most of you know that a big part of evidence-based medicine is relevant scientific evidence, right? This is the part that most of you know that you need to base your evidence-based medicine um, based on scientific research. But the other two parts is most people don't know. Evidence-based medicine has two other elements. One is clinical judgment, and the third element is patient value and circumstances. And this is what we're going to talk about. So in order to um, extract or retrieve uh, scientific evidence, you generally have to formulate your question first. The format that we use in evidence-based medicine is a PICO format. So P stands for population, I intervention, C comparisons, and O outcome. This is a PICO format. And then some people add the last element, which is the type of the study or the design of the study. So you formulate your question, research question. Formulating a research question is the first part before you go seek medical evidence. Excuse me. Ooh. So, for example, if your research question is, should I be prescribing antibiotics for patients who have viral URI? This is your PICO format. Your P is populations, patients with viral upper respiratory infections. Your I is antibiotics. Your comparison is either nothing or placebo. And your outcome, you can decide what your outcome should be, whether it's duration of symptoms, hospitalization, pneumonia, etc. This is how you formulate your question. When you have a focused, formulated question, then you go uh, to databases like PubMed, Embase, Web of Science, and you search for any studies that have addressed the same question that you have. And this usually requires a hefty search strategy. Once you have the papers that have addressed this question, then you have to appraise the studies. Just because something is published, just because somebody has done a study, doesn't mean that this study is valid, doesn't mean that the results are valid. So you need to have some tools to assess or appraise the quality of the evidence. And there are many, many, many tools. There are tools that you can use to appraise quality of randomized controlled trials, observational studies, systematic reviews. Then you appraise the trials, and then once you filter out the the garbage, then you use the ones that pass your quality assessment test, apply it to your research question, and arrive at a decision. So this is obviously a hefty process. This is not something that you can do on a day-to-day basis, but just know that this is a process. And luckily, we have something we call systematic reviews and meta-analysis, and they are the one actually that do this for you. So the best or the highest level of evidence is from systematic reviews because they go through this process very thoroughly and systematically. That's why they're called systematic reviews, because in order to find an answer for a research question, you go through this process systematically and you arrive at the answer. So this is the part that you um, uh, get the evidence. The other part of evidence-based medicine is clinical judgment. One of the reasons why we haven't been replaced by AI or robots is that really nobody can replace clinical judgment. Good doctors, experienced doctors, they think evidence-based medicine, they practice evidence-based medicine. And it's not something that you can replace. Um, there is a book that is, I have it here, yes. There's a book called How Doctors Think. And I think if you have time, this is one of the best books that you should read, and it will tell you how doctors think in general. And it's an amazing book. Again, experienced doctors, the more patients you see, the more experience you have, the more um, your clinical judgment matters. Nothing replaces clinical judgment, even research, even um, uh, AI or nothing. The one thing that this book also highlights, and it's different from clinical judgment, is unfortunately communication is a big part of is a big skill that we need to communicate to make shared decision making with our patients. But doctors generally have no training on how to communicate with their patients. And we really, really, we are bad at it and we don't get training on it. And that's probably one of the most important weaknesses that we have, but how to communicate the medical facts with the patients, how to help them make clinical decisions. Uh, I remember one of my old mentors used to say that, I just make the clinical decision and share it with the patient. But that's not shared decision making, right? It's we need to learn how to talk to our patients, how to communicate scientific facts with them, and then allow them to participate in the clinical decision making. And we'll talk about this a little bit more. But this is the part that I believe most people forget, or most people not are not aware of, and that's patients' circumstances and preferences. We always forget, not always, but we frequently forget what the science is, that what the goal of the science is. The goal of the science is supposed to be helping the patients making clinical decision, impacting their health, right? A large majority of what are published every day in the journals, what we do, all the diagnostic tests, fancy procedures, fancy treatments, have no impact on the patients. In fact, a lot of them harm our patients. All the patients who get stents placed because they have a stable coronary artery, they actually probably get more harm than benefit. All these patients who are on unnecessarily on statins for cholesterol control, all the patients who get treated with antibiotics for viral URI, they all get harmed by it. The focus of the medicine is not on patients. And this is the part that you come in, and you have to make sure everything that you learn, everything that you do actually affects the person that's on the other side of that stethoscope. And this is a mindset that you have to have. What I'm learning, what I'm reading, is this going to really change the patient? The one interesting example is, I don't know if you're aware of that, the new medicine that was approved for Alzheimer. Was it last year or 2024, 2023? And it showed that it reduced the amyloid burden in the brain in patients who had Alzheimer, and it got approved by FDA. It had absolutely no clinical benefit to the patient. It reduced it was a surrogate marker. It reduced the amyloid burden, but it did not improve patients' uh, memory or function or anything. But it still got approved, and it's a fancy, expensive drug that most people are going to prescribe for the patient, not knowing that it had absolutely no benefit for the patient. So these are the things that I want you to keep in mind when you think um, about medical interventions, medical tests, and medical treatments. But in evidence-based medicine, the outcomes have to be patient-oriented. Patients are the center of the universe, center for everything we do, and therefore they have to be what we do. We have to adjust for their circumstances and for their preferences. I worked I worked last Friday clinically, and in the morning, I one of my colleagues endorsed a patient to me, um, a man in his 50s who had diabetes, and he had uncontrolled diabetes. His sugar was more than 500, and they he had multiple admissions in the past, and because they couldn't control his sugar, they requested a consult from endocrinologist. And when I got to work, I saw a group of endocrinologists with clean white coats going to the patient's bedside. In my hospital, when you see clean, nicely ironed white coats, they're either dermatologists or endocrinologists, because they're face to face with patients are less. Our scrubs and white coats are always bloody and dirty because we are down in the trenches, and they're down in their nice clinics. But that's just an observation. So they came, they saw that gentleman, and then I read the consults when they left. It was beautifully written. It was all scientific based. It was all based on evidence. They said, his hemoglobin A1C is 15, therefore he needs to be on insulin. He should take 10 units of insulin after each meal 3 times a day, and then he has to take 20 units of Lantus long-acting insulin at night. And then they wrote almost 2 pages of how his diet should be, what percentage of his diet has to be carbohydrates and fat and protein, and what he should eat more vegetables, fruit, and all that. And he has to check his finger stick 3 times a day. It was beautiful. And my resident was about to discharge this patient. And it occurred to me, let me go check, make sure he really understands this. And I went to the room and I saw that he had two large garbage bags next to his bed. That was all his belongings. And he was suffering from a severe case of toxic shock syndrome. You've heard of that? Toxic shock syndrome? No. All right, we'll talk about it later. He was very disheveled, very unkempt, and he was homeless. And I asked him, "Where do you live?" He said, "I live on the subway platform. I live on the subway or on the subway platform." And I said, "What happened to the insulin that we gave you last time?" And he said, "When I go to the shelter, people steal it from me because the insulin and diabetic supplies are extremely expensive in the US. So people sell it for cash in the street, or people steal it and then go sell it." So he lives on the subway or subway platform. Uh, if he go to shelter, they steal his stuff. How do you expect a homeless man to check his finger stick 3 times a day? How do you expect him to give himself insulin on the subway 3 times a day? And then just the laughable part was that the dietary recommendation. The man is homeless, doesn't have anything to eat. So you see the disconnect here. The scientific part was perfectly done, but they did not put connect with the patient. They did not consider the patient's circumstances, the patient's uh, situation. So the recommendations were completely useless, right? So you get the picture. Everything we do, we have to think, is this going to work for my patients or not? How is my patient going to use these recommendations? Or what are the preferences or circumstances that this person has that I need to adjust to, right? Another example that I just makes me emotional when I think about it. National Institute of Health, where you get most of the funding for the grant uh, in the U.S. Every year for different pathologies, they invite experts to a symposium, and they brainstorm about where should the money go for specific diseases. And this was uh, a brainstorming think tank symposium on patients who had the spinal cord injuries. So they invited almost 300 people, neurosurgeons, neurologists, emergency physicians, anyone, chiropractors from the country, anyone who had done research in the field. They invited everyone to this symposium to think and talk and discuss where should we dedicate our resources, our funding for research to improve the health of the people who have spinal cord injuries. And of course, the 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 people had a lot of suggestions, a lot of recommendations. We need to do research to improve how they move, how they walk, how they take care of themselves day to day. They were talking about nerve stimulators or muscle stimulators that were controlled by chips that you put in the brain and allows the patients to move their arms or even walk. We're talking about robotics. Um, Everything was focused on how do we get the patient with the spinal cord injuries to move around and be able to take care of themselves. And it just went for hours. And by the end, closer to the end, we realized, everybody was so excited that all the spinal cord injured patients are going to be able to walk very soon after all these ideas are implemented. And then one beautiful thing that NIH does is they always invite a patient advocate to this symposium. So there's always a patient or a patient advocate who is also a patient who is suffering from the same disease to this symposium. And there was a gentleman who was there. He was a spinal cord injury patient sitting on his wheelchair. And the moderator, at the end of the session, the moderator said, um, let's ask our patient advocate, what do you think? So he was really nice gentleman, very shy. He wheeled himself to the podium, and everybody expected, you know, praise that, my God, you guys are going to change our lives. Thank you very much. And he said, yeah, it's, thank you. This was really good. This was very hopeful. But, and then like there was a really long pause. Everyone said, oh, but what? And he said, don't get me wrong. I would love to be able to walk one day. But if I have a choice, my preference is bowel and bladder control. And just the silence was deafening. There was a long silence. Everybody, these are people in this room had to spend decades of their lives dealing with patients with the spinal cord injuries, and didn't, they still got it wrong. That what the patients prefer, it probably it's different from what we have in mind. You don't know until you ask the patient, right? So this is again the part of evidence-based medicine that I want to emphasize. Don't forget that all this science, all these interventions, all these medications, they have to fit the preferences of the patient. Otherwise, they are all useless, right? They are going to serve the pharmaceutical companies and corporates who run our healthcare, but they are not going to help the patient. And a lot of time, you will not know until you don't until you ask. Again, a lot of these people in this symposium, they had to spend their entire career with working with these patients, and they still got it wrong because they thought that they knew what they wanted. But when you ask, things change. I'm sure you have learned about CPR and cardiac arrest, and you give epinephrine to the patients, right? This is something that we've been doing for God knows how many years. This was a study called Paramedic 2 study. It showed they enrolled patients with cardiac arrest, out of hospital cardiac arrest, and they randomized them to epinephrine versus placebo, and to see how that affects survival. The study showed that more patients who received epinephrine, they got their pulse back and they made it to the hospital. But at 30 days, the number of people who died and the number of people who had acceptable neurological function, meaning people who are able to take care of themselves or take care of themselves with help, was not changed with placebo. So this is an example of one treatment that makes us feel better because we get the pulse back and we high five each other. But on the patient end, it doesn't change anything. In, they either going to die or they're going to be bedbound, dependent for the rest of their lives. This is a definition of a patient-centered outcome. Which one of these three is patient-centered outcome? Getting the pulse back or neurological function? What do you prefer? Neurological function, being able to live independently or with help, and not being bedbound and a vegetable on a bed for the rest of your life. Any medication that doesn't change that is useless, right? So that's an example of um, patient-oriented outcome. And this is my favorite. The statins for primary and secondary prevention. Primary prevention is people who have high cholesterol, but they haven't had any heart attack or any stroke in the past. That's for primary prevention. Secondary prevention is if someone had a heart attack or a stroke, and then you give them, uh, you try to lower their cholesterol to prevent future heart attacks or future um, stroke. That's a secondary prevention. The, this is a multi-billion industry. The companies are making more than $40 billion a year selling statins. And this systematic review combined a very large databases of um, studies that have enrolled patients for statin studies. And it showed if you take statins for average of 5 years, your life is going to be prolonged by average of 3 days or 4 days, depending on if it's primary or second. 5 years of taking statins, that means costs, making appointment to go see your doctors, copays, side effects, all of that for 3 days living longer. Is this a patient-oriented intervention or not? Right? This is the way, this is an interesting way of looking at research. A lot of research that we've done so far just says, you placebo versus control. If you give patients a treatment, they reduce this or that by 5% or 10%. But now the new way of research measuring outcome is how long, if I'm giving this medicine to prevent, to reduce the risk of MI, how long does this patient has to take this medication to postpone or prevent one MI? Like you say, if you take this medicine X, it's going to delay your second MI by 10 years, or it's going to delay your death by this many years. So it's kind of longitudinal outcome as opposed to just throwing numbers at the patient. Yes. So one of the main issues with the statins is more than half of the patients, they discontinue the medication because of side effects, because of the muscle aches, muscle pain, diabetes, and other things. But for these are patients who took it for 5 years and didn't stop it. So if you just re religiously take your medicine for 5 years and go to all those doctor's appointment and refill medication and everything, you do everything right, you're gonna be paying rent and mortgage 3 more days. All right, so going back to the different components of evidence-based medicine, there are three components. One is the best evidence from research, use your own clinical experience, and then combine it with patients' values and expectations. And this is the part that is probably the most challenging for all of us, and we don't have enough training. How do I communicate the best evidence with my patients, considering their values, their preferences, and how do we come up with a shared decision on their treatment? The most people, even most doctors, most patients, and even most doctors, they think that if you have pneumonia, you take antibiotic, pneumonia is going to go away, right? They think that if you have cough and fever and that you get the chest x-ray, and if there's consolidation is there, you have pneumonia, and if you don't, if there's no consolidation, there's no pneumonia. Most of us think black and white about treatments that we give. If your child has um, sore throat and you do a strep test and the strep test is positive, the child has strep. And then you take the medicine and the strep goes away, right? This is how people think and most doctors think. And unfortunately, this is wrong. And this is where I want you to change how you look at treatments and diagnostic tests. In reality, for every single disease treatments. When you treat something, there is a group of patients who are going to benefit from that treatment. There is a group of patients who are going to be harmed by that treatment. And there is a big chunk of people in the middle that are not going to benefit from it, right? Let's repeat this again. Every treatment that we have, almost every treatment, there's some group of patients who are going to benefit from the treatment, some group of patients, a group of patients that are going to be harmed by the treatment, and a good chunk of people in the middle that's going to be neither that neither going to benefit from it or be harmed by it. And this is the part that again we need to change our mindset. This is how treatments work, and we have to communicate this with our patients. Again, the part of communication with the patient is something that we are lacking and we need improvement. I'm giving you this antibiotic for your pneumonia. It most, research has showed that it works in this percentage of patients, but there's a good chance that it might not work and it actually might harm you. Or, uh, you know, treatment by treatment is different. Some treatment have more benefit than harm and less people with no effect. Some treatments are small benefit, more harm, and some treatments have absolutely no benefit. It's either no effect or harm. Antibiotics for viral URI is the last part. Will you ever consider the third option for any of your patients? Small benefit, a lot of harm, and some good size, no effect. What would be the scenario that you would use this? Very good. Same thing. So you're right. It depends on the disease, right? If you're treating uh, 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 let's say very malignant cancer with very low chance of survival, any benefit you'll take it, right? Any chance you can uh, delay death or prevent death, you'll take it, even you know at the cost of giving them a very toxic, very um, toxic chemotherapy that will have a lot of side effects. But you're taking your chances because the disease is very lethal. So everything is disease specific. For you have to, this is again the part that clinical judgment comes in. There's no formula to tell you how many, how much benefit or how much the benefit should be more than harms or how much harm you're going to accept. Is disease specific. It's patient by patient, case by case. It's your clinical judgment and it's the decision that you discuss with the patient. This is what we have. The harms are significant, but you might benefit from it. It might delay your death, it might delay your MI, it might delay your stroke, and then let the patient decide. This is clinical judgment. And for diagnostic tests, there's really no diagnostic test that has that is 100% accurate. Maybe autopsy, but there's really no other diagnostic test that is 100% accurate. We just have to remember tests have true positive, tests have true negative, and there is a bunch of false positive, false negatives in the middle. The when patients take their parents take their kids to um, the doctor for sore throat and they do a test for strep and the strep is positive, the doctor tells the patient, the parent, oh, he has a strep. I'm giving you antibiotics. The the doctor is happy. Parents are happy. They pat themselves on the shoulder. That's a great. I'm glad that I took the day off to bring my patients and saved him or her from the strep. But the part that's missing, that depending on the area, you can have 5 to 20% false positive rate for a strep throat, right? Because strep can live in your throat as a normal flora with no harm. And now you're subjecting this kid to 10 or 14 days of antibiotics, rash, diarrhea, vomiting, and sometimes serious, more serious side effect. Forgetting that to communicate with the patient that there's a good chance of false positive with every strep test. So you're only supposed to test a child with sore throat for a strep if they are high risk, meaning they have fever, they have cervical lymphadenopathy, they have exudate. But every child that goes to the pediatrician or urgent cares, they get, even though there's, the throat not even is not even red, there's no fever, there's no lymphadenopathy, they test them and then they catch that 20% false positive and subject the patients to harm. Uh, and this is the part again, it's a fault from us as doctors and the patients. We think tests are 100% accurate. If it's positive, it's positive. It's negative, it's negative. That's not true. So I want you to to keep this in mind. Again, repeating, treatments. No, there's no treatment that has 100% benefit. Every every treatment has three elements: um, efficacy, harms, no effect. And diagnostic tests similarly have false positive, false negatives, and this has to be communicated with the patients. So the what we like in evidence-based medicine to promote how to understand the treatment efficacies and how we communicate the treatment efficacies with our patients is the number needed to treat, number needed to harm, and number needed to diagnose. These are things that are easy for people to understand. You cannot talk to your patients and give them relative risks and percentages and relative risk reductions or anything like that. They don't understand it. Even most doctors don't understand it. But the idea of number needed to treat is easy. How many patients do I need to treat for one of them to benefit from it? How many patients with pneumonia do I have to give antibiotic to for one of them to, uh, you know, end in resolution of symptoms or duration of symptoms? Or how many of them I have to treat for one of them to prevent a hospitalization? This is relatively easy to understand. How many patients do I need to give a statin to for one of them to get, experience muscle aches, right? Do you agree? This is a relatively easy uh, concept, and you will be amazed by the treatments that we are giving to the patients as really written on a stone in terms of benefit, what their NNT is. People who take aspirin for secondary prevention to prevent future MI and stroke is 1 in 40. So if 40 patients have to take aspirin for the rest of their lives for one of them to avoid one MI or stroke. And this is probably as good as it gets. There are other treatment that is the NNT is like 250, 600. A lot of treatments that we give, the NNT our NNTs are amazingly high. And when you tell the patients, hey, you need to take this medicine for the rest of your life, and out of 40 people who take it, one of them might avoid an MI, patient might still take it, but at least they know it's their decision and it's their choice, right? Having said what I said, this idea of deliberate clinical inertia was developed by this Dr. Fatovic from Australia. That in his opinion, not doing anything for a patient is probably the best thing in most scenarios, right? People need reassurance. People need things to be explained to them, but a lot of time doing tests can harm them. You do an unnecessary chest x-ray for someone who has cough and has no fever, no crackles, nothing. They have a cough, you get a chest x-ray. Do you think the patient is going to be harmed, possibly be harmed by this x-ray? Probably not, right? It's a small amount of radiation. But what if you find a small nodule in the lung? A nodule that's probably benign and doesn't do anything. If you didn't know it, nothing would happen. But now you see a nodule. This nodule has to be followed up by a CAT scan or another X-ray in six months. And if that CAT scan or X-ray is not definitive, then the patient might need a bronchoscopy and biopsy. And then something that probably that is benign in 99.9% of the time, now you subject your patients to procedures, further radiations, further doctor's visit. So keep this in mind. Every test has side effects. Every test has side effects. The strep test that you did on that kid, it had side effect. The side effect is that that child has to take 10 or 14 days of antibiotics and experience side effect of antibiotics. Every test, every procedure, everything has side effects. A lot of things that a lot of patients that we see, they don't need anything. Diagnostic inertia, reassurance, you don't need anything. You're coughing, you have runny nose, you're miserable. I understand. But you're going to be okay in 4 or 5 days. Drink a lot of fluid, take Tylenol, rest, you're going to be okay. You don't need to give them antibiotic. You don't need to do tests. You don't need to do unnecessary x-rays, MRIs. Every test it has false positive, and false positives put your patients at risk of future procedures, future tests. All these PSAs that are done on patients who have prostate enlargement. A lot of them, you know that a lot of prostate cancers are in situ. Statistically, people who have in situ prostate cancer, they die from other causes. It's not the prostate cancer that's going to kill them. But you keep sending PSA, and then when you PSA is elevated, this person is now going to get the required biopsy. Biopsy shows cancer. Now you have to do surgery or treatments that put the patient at risk of impotence and urinary incontinence. If you hadn't done that PSA, this patient would have been fine, would have died from other causes, and the prostate cancer would have been completely innocent. So this idea of deliberate clinical inertia, keep it in mind. This is something that you should be practicing most of the time. So how are we doing with time? You good? Okay. The first rule of evidence-based medicine is do no harm. Do nothing. Don't do harm. Don't prescribe unnecessary medications. Don't do unnecessary tests. This is the part that ABM is at disadvantage because people like certainty, right? When you listen to, when you go to check the weather, you want to know whether it's going to rain or not, right? But instead you get 35% chance of rain, 40% chance of rain, 50% chance of this or that, right? Or when you take again your child to the doctor, you want to know whether your child has strep throat or not, right? And we just mentioned that that's not going to happen. Medicine is all about uncertainty and probability. When you have a patient that you pick up a patient's chart and it says right upper quadrant abdominal pain, right? You immediately in your head, you develop a probability of maybe this patient has gallstones, right? You go to the bedside and you touch the right upper quadrant is tender. The initial probability that you had in mind for gallstones now goes up a notch, right? Because now the right upper quadrant is tender. You ask a few questions. The patient said, after meals, pain is worse, and then there's nausea and vomiting. The probability goes up a notch. You do an ultrasound, you see a stone in the ultrasound, your probability goes up a notch, right? So how we make decisions is all based on probability. There's nothing 100%, nothing goes to 0%. If you do a test and it's negative, it reduces the probability of the disease. And if it's positive, it increases the possibility of the disease. And when I talk about tests, Test could be physical exam, history, or lab work or imaging. Any piece of medical history, any piece of physical exam is a test. And we all work by probability, right? If you, when you collect information, when you do test, you get to a point that the probability of the disease is now very high. And now I'm going to stop testing. I'm going to stop asking questions. I'm going to treat the patient. If you do test, collect information, the probability goes is low enough that I can send a patient home, right? Rule out the disease, send a patient home. So at what threshold do you decide to treat and what threshold do you decide to rule out? Again, it's disease dependent, right? If you are going to treat the patient with chemotherapy for a cancer, you better have a very, very, very high probability, right? Or if you're trying to rule out pulmonary embolism, you want to have you want to have a very, very low probability before you can rule out the problem. But if you're talking about ankle sprain or a UTI, uncomplicated UTI, the threshold might be a little bit more relaxed. It doesn't have to be 99%. So this is how we work. But the desire for certainty is something that is one of the basic desires of humans have. You want certainty, and that's why uh, when all these TikTok or Instagram celebrities, so people who give medical advice to people, if you listen to them, they are certain. There is no doubt. They never give you any indication that they have any doubt about it. I am a gut doctor, and these are the 5 things that you need to eat to, I don't know, do this or that. Or I am a cardiologist, and these are the things that if you do this, you're going to live forever, right? There's no doubt in them, and that's why people give them likes and follow them because they are certain, right? Uh, when you go to buy a house, your expectation is that the house that you're going to buy meets 100% of your expectations. Everything has to fit in. But as we grow more mature, as we become more educated, as we gain more experience in life, we realize that there's nothing certain in life. There's absolutely nothing certain in life except for death and taxes. But in medicine, there's really nothing certain. And this has to be something that you have to embrace as a medical doctor, and you have to communicate that with the patient. There's nothing certain. But people like certainty. And they're one of the reasons why certain demographics are drawn to Trump is because he can tell you the most ridiculous lie, but he says it with such conviction and so much certainty that people say, "Hey, it's people like it." He says, "Vote for me, and I end the war in Middle East in the first month of my office," and people say, "Oh my God, he's going to end the war in the thing. I'm going to fix the immigration." You can lie, give the most ridiculous lie, but as long as you appear certain, people are drawn to that. And as medical professionals, we have to distance ourselves from that thought, and we have to communicate that with our patient. Nothing in medicine, nothing in life is certain. It's all about probability. It's about embracing uncertainty. And the treatment that we give, the recommendations that we give, it's all based on uncertainty. I wrote a piece many years ago, and I compared evidence-based medicine to democracy. Democracy is also based on uncertainty and ambiguity, right? You can have any political belief that you have, but you always have to understand that you could be wrong, and the other party, other person that with the opposing view might be right, right? This is the fundamental principle of democracy. That's why the military regimes, the tyrannies, the religious regimes, they never can coexist with democracy, because democracy is all about ambiguity and uncertainty and the possibility that you could be wrong. But a tyrant, a religious leader, a king knows the answer to everything. They know what's good for the patients, or at least they claim that they know what's good for the country, what's good for the patients. There's no uncertainty, there's no ambiguity, and it doesn't work. Now I'm just making up rules. The third rule is people don't care how much you know, but they until they know how much you care. Pass this one. All right. So where do you find the evidence? If you are looking for scientific evidence, where do you find it? This is why systematic reviews and meta-analysis are the highest. This is the hierarchy of evidence. This is where systematic reviews and meta-analysis are the highest level of evidence because they combine the different studies. They get different studies that were done on the same research question, and they analyze them, they put them together, and they give you an answer after going through that cycle that I explained. You look for the evidence, you create a formulated question, you look for studies that have addressed that question, you appraise the question, you filter out the studies that are flawed or they have limitations, and then you have a few papers that have addressed the same thing, they are with high quality, combine them together, arrive at a conclusion. That's what a systematic review does. And it's called a systematic review because of the systematic approach to identifying the evidence. You rarely should change your praxis based on one RCT or two RCTs because the sometimes the populations are different, the circumstances are different. You need more than one study to arrive at the conclusion, and that's why systematic reviews that combine these studies are helpful. The one thing about systematic reviews that you need to remember, just because something is a systematic review is it that's a highest level of evidence because the systematic review itself has to be done properly. Unfortunately, these days you see a lot of systematic reviews that are coming out that they have flawed methodologies. For example, if your research question is something therapy related, you only have to include RCTs in the systematic review. There's no other way. It has to be randomized control trial. You cannot use observational studies or retrospective studies for a therapy question, right? Because you want to make sure that all the confounding variables have been addressed and have been accounted for. So if you see a systematic review that is about the therapy, but they have included retrospective studies or observational studies, that systematic review is flawed. So the terminology that's used is a garbage in, garbage out. If you include garbage in your systematic review, the systematic review is going to be garbage. So the methodology of the systematic review has to be appropriate. And frequently you see in systematic reviews that they tell you that we looked at these papers and the studies had a lot of biases and the studies were of um, poor qualities, and then at the end they make strong recommendations. They draw strong conclusions. If the studies were bad, if the quality of evidence bad, then you're not supposed to draw strong recommendations. This is a an open access website called the nnt.com. Uh, I'm the disclosure. I'm the editor in chief for this website, but it's free and free access. We don't have any financial conflict of interest. We have no supporters, nothing. So this is where you can go and check, especially when you get to clinical work. If you have a question and you want to get a quick answer, my patient has sore throat. Should I give them a steroids or not? And you can go here and it will give you um, the NNT. If you give you 1 in 5 patients are helped complete resolution of symptoms in 24 hours. And we have a traffic light system. Green means the benefits are more than harms. Yellow means the data is equivocal and we need more data. Red means the probably harms and benefits are the same, and then black means harms are more than benefits. So You go here quickly, and there's usually it's a systematic review source. There's a one-page summary at the bottom. It tells you how they have arrived at this number. And this is an example of a red recommendation. This is therapeutic hypothermia after cardiac arrest, that the harms and benefits are almost the same. So this is a website called thennt.com. And calculating NNT is really easy. I don't want to go into statistics, but this is really not statistics. It's very, very easy. You choose your outcome, and then you calculate the risk of outcome in the study group. You calculate the risk of outcome in the control group. You deduct that difference between them. It's called absolute risk difference. And then NNT is 1 divided by absolute risk difference. It's really an easy math. And it tells you NNT is 20. 20 means you need to treat 20 patients with this hypothetical drug for one life to be saved or for one death to be prevented. This is something that you can communicate with your patients, right? There's no statistics here. There's no relative risk reduction, odds ratio, or anything complicated that patients are not going to understand. But this is a very easy way for you to understand and for your patients to understand. And for harm, it's the same thing. You calculate the harm in the study group, calculate the harm in the control group, the difference, absolute risk difference, you calculate it, and then oh, that has to be NNH. Number needed to harm will be 1 divided by ARD, and you say 10 patients need to be treated with this hypothetical drug for one of them to experience adverse events. Uh, just quickly, talking about absence of evidence versus evidence against. This is something that people confuse all the time. If we don't have good evidence that something works or something doesn't work, it just means that the jury is still out. Doesn't mean that the treatment doesn't work. We can say we don't know. But sometimes we have good evidence that something doesn't work. That's evidence against. That is fine. So if you have solid evidence that says antibiotic don't work for URI, that's evidence against, that's an acceptable evidence, that's useful evidence. We know it doesn't work. But if we say that we don't have any evidence to tell you whether taking I forgot the name of this thing that is supposed to prevent cancer. Some supplement is supposed to treat cancer or not. If you say we don't have any evidence, it doesn't mean it doesn't work. It means we don't know if it works or it doesn't work. This is something when people get confused. You don't have any evidence that if you jump out of an airplane without a parachute, you're going to die, right? There is no evidence because nobody has studied it. Doesn't mean that you can jump out of the airplane without a parachute. No. So just because we don't have evidence doesn't mean something doesn't work or doesn't work. It just means we don't have enough data to tell you whether it works or it doesn't work. This is a this systematic review was published closer to the end of COVID, and it showed the conclusion was the studies that it was about masks for preventing a spread of viral diseases, including COVID. And the systematic review concluded that the small studies that we have are very small, the studies are flawed, the quality of evidence is bad, so we don't have any evidence that masks prevent transmission of diseases. Does this mean masks don't work? No, it just means we don't have good evidence, right? So this is what all these celebrities and all the anti-maskers and vaccines use. Here you go. Systematic review shows that it doesn't work. No, systematic review just shows that we don't have any evidence to support it, but it doesn't mean that it's still wrong. So just keep it in mind that this could be confusing. Evidence against is different from evidence absence of evidence. I like to put this at the end of my lectures just to as a reminder that you're You're going to be doctors. You're going to be spending most of your uh, uh, youth youthful life in the libraries, staying overnight, working with patients, observing a lot of suffering, and you're going to dedicate a good chunk of the best times of period of your life to your patients. Uh, and it could be frustrating, could be depressing at times, but just remember that somebody's life could be could change because you showed up to work that day. Sorry, this I get a little bit carried away with politics and other things and examples. This is something that I'm passionate about. Um, it was a little bit longer than I expected, but I'm open to questions, opinions, ideas, recommendations. Yes, ma'am. Yeah, thank you. That's a good question. So the question is when people with conflict of interest, um, they're implementing their ideas or they're pushing for their policies, um, do they really use evidence for those, or how do we as physicians how what's our responsibility? They 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 are very clever. If a drug company is pushing for a treatment, everything is very subtle. Everything is very all the flaws that they are inserting in their recommendations are very subtle, and they are becoming more and more clever in packaging their ideas or packaging their recommendations that will serve them and the patients. It's our responsibility to learn the tricks and learn how to expose those flaws. They never come, of course, they never come out in the daylight and say, I'm doing this because it's going to serve me. They're going to tell you, the advertise for the patients on TV, this is going to save your life. And there are, hopefully, when you go a little bit more advanced, I'll come back and give you a lecture about how to identify biases or flaws in published papers. And there are many, many ways they can spin the results to present it in a way that people think, oh my God, this is going to save my life. But we need to, this is a skill. Again, as I said, unfortunately for you, you need to protect your patients. And this is going to be a set of skills that you need to learn. How do you filter out the biased and conflicted recommendations from unbiased and unconflicted, because they definitely don't use the evidence, but they know how to package it as evidence. The questions? Yes. Yeah. It's challenging. It's challenging. The mistrust of science has grown exponentially, especially after COVID, after public health became political, the politics got involved. It doesn't help that the president at that time told people on TV that doctors, if they kill the patients, they get more money. That definitely didn't help the situation. uh, And also over the years, I think people have realized that they have been lied to by pharmaceutical companies, and they have lost their trust in medicine. So as scientists, we have to restore that trust, and that's going to be hard. That's going to be very challenging. The art of communicating with the patients and how you can get them to trust you again is extremely important, something that we need to learn. How do I, if someone, as you said, tells me that they did this, they learned this from TikTok and they did it based on TikTok recommendation, how do I change their mind and make them listen to me or the science rather than it's very hard, and it's not something that we teach or learn, but there are recommendations, there are steps that you can take. There's the first thing that you do, it's a whole different talk, different lecture, but you have to connect with the patient. You have to validate. It's just like dealing with the child. You have to validate how they feel. You have to validate their beliefs first. You can't come from a point of arrogance and say, "Oh no, you shouldn't be doing that. You should listen to me. I'm the doctor." That's not going to work. You have to validate why they did that and then connect with them. Find a point of connection. Find something that the two of you can connect. Because now patients come to the offices or to emergency room or to urgent care, everybody's guard is up. They think that they're coming to the doctor, and there's a very likely that the doctor doesn't have their best interest in mind. You have to make them drop their guard. And that's by validating their feelings, making connection, and then learning how to talk to the patients. You cannot throw percentages and statistics at them. You have to tell them communicate the science with them the way they understand, and you have to reassure them that their best interest, their preferences, their circumstances are the most important element of that decision making, shared decision making. It works, it requires a lot of work, it requires a lot of training, it requires a lot of practice, but it is possible. Any other questions? I don't have a TikTok. I probably should have one, right? But it's not going to sell because all I talk about is uncertainty, right? Nobody's going to like my TikTok. So uh, if 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 I was certain about some things that I said, then it would have maybe it would have worked. Yeah. All right. Thank you, guys. So starting tomorrow, we'll talk about neurological emergencies. Thank you. I'm sorry it went too long. Thank you.